news, literally and metaphorically, in the area of disorders like chronic cough, not only identifying the causes, but also developing programs that help these kids. So it is something that we see very, very often, especially this past year. And it is great to hear from the person who has done probably the most work in this area. I would also like to commend Dr. Weinberger because from what I understand, he's in California, which means that he had to get up at 4 o'clock in the morning in order to be with us today. So this is an extra sacrifice. So Miles, thank you very much for joining us, and Mr. Deutner, and we are ready for your talk.
Thank you, Tezes. You kind of gave away my age by telling me you were a fellow when you first met me, and but
I started very early.
Okay. Okay, so this is the presentation, Functional Respiratory Disorders in Children. And for those of you who haven't yet received this publication, which just came out, if you want a PDF file, feel free to email me and I'll be happy to give you one. So functional respiratory disorders are those which have no organic or anatomical basis. And they tend to cause diagnostic problems for physicians, and as a result, patients get treated for a lot of things that they don't have. Physicians treat for things that they know, and sometimes it's left up to the patient to figure out what really is going on. So I have no conflicts of interest regarding this topic. So what are the functional respiratory disorders? They include habit cough, vocal cord dysfunction, of which there are two phenotypes, exercise-induced and spontaneous. Hyperventilation, which is also both exercise-induced and associated with panic attacks. And then there's functional dyspnea and sighing disorder. And I'll go through those. Some of them take more time than others. We'll start off with habit cough. And if we're going to talk about habit cough, I think it's important to put it into perspective with overall chronic cough. And this was a beautiful study done by Annie Chang's group from Brisbane, Australia, a multi-center study on chronic cough in children, etiologies based on a standardized management pathway. And this setting was Australia and New Zealand at 5 major hospitals, 3 rural remote clinics. So these were referred patients now. 346 children referred for chronic cough. Chronic cough in children is defined as more than 4 weeks duration. In adults, and just to avoid people might be confused by this, but adults it's defined as more than 8 weeks. These are somewhat artificial definitions. The mean age of this group was 4.5 years. And here's what they came up with. Now, I'm not going to go through all of these. That would be a separate presentation. What we're going to do is focus on the what they called habitual cough, or what I call a habit cough, and that was 4% of this identified 346 patients. What are the characteristics of the habit cough? And we'll also go into where it gets its name. The classical clinical characteristics are a repetitive, dry, barking cough. The cough it tends to be very annoying to people. It's much too loud usually to prevent school attendance. But there are variations. They're not all the same, and I'll be showing you some of those. It's commonly misdiagnosed as asthma, although it shouldn't be, because it really doesn't have any resemblance to asthma from my point of view. But cough from asthma is something that physicians know, so they treat that. But there is no response to medication. And a sine qua non is the absence once asleep, a very important part of the characteristic, and that sits and very important for identifying whether or not a chronic cough is that is a repetitive dry cough, is whether or not it's present or absent during sleep. The epidemiology of habit cough comes from two studies. One is one at Iowa, where we had 140 patients over a 20-year period, and that was a mean of 7 per year. And at the Brompt Hospital in London, they identified the patients exactly the same way we did, and they found 55 over 6 years, and that was a mean of 9 per year. So that gives you 7 to 9 per year is about what you could expect at a major referral center like the Brompt or the University of Iowa. The mean age at both places was 10 years. Both genders are represented, and the cough could be present for weeks, months, and even years. And again, the diagnosis at both places was the same way: repetitive cough, absent during sleep. There are no tests involved, and some reviews in the past have said, well, you have to diagnose it, you have to exclude all other known causes of cough. That is nonsense. Okay? It has its own, this is a characteristic presentation. So it's a clinical diagnosis. And that was exactly how the Brompt did it, and that's how we did it. Secondary gain is not commonly present, and psychopathology is not commonly present. So let's look at the, these are home videos that parents provided to my colleague, Dennis Buettner, who's with us also. And he put it together, and we have, as I remember, I think 5 different home videos linked together here to show you the different types of cough. And particularly, I'd like you to pay attention to the second one I'm going to show you, because the cough is rather subtle, and you have to watch and listen carefully.
What's Juby and want to do? That's how to do the game.
That's how you do the game?
Did you get that cough?
You want me to be Spider-Man?
Watch once.
Okay, you'll be Spider-Man, I'll be Spider-Man, and we'll fight the bad guys. Is that a good idea?
There's another cough.
Fist bump. Okay, slap, slaps. High five. Nice, bud. Okay, now where we go?
There was another cough. So at least once a minute, he's having a cough. I'll introduce these afterwards. So I'm moving along because so that we have time for everything.
They got not all of them, but loads. They got two. They got birds. Well, the birds are not just the normal birds.
Emily is British, even though she's living in Spain.
They got
First thing I'm going to do.
Now, Abby in Australia has been doing this for 5 years, since age 10. And right now she's listening to me, to a recording of me talking to Mr. Buettner's daughter, Bethany. And you'll see more of that later.
But if you really concentrate, you can hold it back, at least for a few seconds, right? You can do that. Okay. So even though the cough comes in.
Oops, I didn't mean to do that. That's all right. Well, fix it up.
With you. And think about nothing but controlling that nasty.
Okay, so that was a demonstration of she was starting to have, from listening to that, progressive periods of time between the repetitive coughs. So those were examples of habit cough in children. And you see the number of them had the classic, very harsh barking cough. Others were like the little 3-year-old, which is the youngest one we've seen, who coughs every second into his elbow, but doesn't let it bother him. So, how do we treat habit cough? Well, it was first described, at least the oldest one that Dennis Buettner found for me, was described in 1694. And it fits what we very often get a history of today. They talked about the habitual cough, which often continues after the first cough, which was caused by a cold. The cold is gone, but then the cough, the habitual cough, continues. And that's a very common history that the vast majority of both kids and adults describe. They had some respiratory illness, and I've heard parents say, well, they had an ordinary cough, and then after a couple of weeks, the cough changed and became this habit cough. So what do you do about it? Poor guy here doesn't know what to do, and unfortunately, a lot of physicians don't know what to do either. But it has been described and treated since 1966, and also in 1984 and 1991. I'm going to go through those cases because they're informative. So this first study from 1966 was Bernard Berman, a Boston averageist who unfortunately is no longer with us. He described 6 children that he'd seen over a 5-year period with a daily barking cough, frequent, and he noticed that he described it as being frequent, repetitive, and absent once asleep. Again, the characteristic. Ages were between 9 and 13, boys and girls. And he described that these coughing, these children, these 6 children, the cough stopped with what he called in his article, the art of suggestion. He also discussed the nomenclature for this because there have been previous reports, isolated case reports that some people would call psychogenic or a tic. But he felt the term habit cough was most appropriate based on his observation and the ease with which he was able to cure them. Another method that was used and reported in 1984 by Cohen and Stone was what was called the bedsheet. And then there was another one that came out that was called alternative to the bedsheet. And I'll go through these quickly. The bedsheet technique was based on the physician telling the patient that the coughing had caused weakness of their chest wall, and the wrapping the bedsheet around it tightly would strengthen it and enable them to stop coughing. So this again was a form of suggestion, but using a physical, not quite truthful physical means of stopping them. However, he described 33 children treated this way over 25 years, and then with a follow-up, he said 31 were successful. Very nice study. The alternative to the bedsheet was because these physicians didn't like that it was an aversive technique. And they described 4 children who they treated just by having the parents monitor the cough and rewarding them for making the cough less frequent. The first study we did was in 1991. And the index case that led to the study was a 15-year-old girl with months of intractable cough. A very nice young lady, did well in school, had lots of friends, was obviously upset. And as had been done with many patients over the previous 20 years since I've been in Iowa, since 1975, I stopped the cough with 15 minutes of suggestion therapy. Dr. Lokshin, Boris Lokshin, was my fellow at the time, and he was very impressed. It was the first one I'd seen. And so he asked, is the quick fix permanent? And so the natural thing for me to do was to tell Dr. Lokshin, find out. And so we had my nurse do this was before electronic medical records, had my nurse, Jean Kovach, do a manual review of clinical charts and found 9 patients with habit cough. And they were 6 to 17 years old. And they were routinely contacted a week after the initial suggestion therapy. And one of them had no symptoms. 8 described minor self-controlled symptoms. That is, they needed no further medical care. They were able to control their cough. Dr. Lokshin was able to contact 7 of the 9, an average of 2.2 years later in those. One of them was much longer, I think almost 9 years afterwards. And 6 of those 7 that he was able to contact had no symptoms. One of them described minor self-controlled symptoms. Another investigator in this was Dr. Lindgren, who was a clinical psychologist in our department, who gave them a standardized test called the SCL90R, which is designed to look for somaticization and other abnormal behaviors. And they found no abnormalities. One had a borderline obsessive compulsive scale, but not clearly in the range of abnormal. probably just in the range that you'd expect maybe from a good physician. He wants someone, but it was not pathological. So how did we treat the patients? We decided to take a look at this, and this report in 2016 at the cough without a cause, the habit cough syndrome. They had these 140 patients. That this time we identified the diagnosis through our electronic medical record over a 20-year period from 1995 to 2014. Mean age was 10 years, range was 4 to 18 years. That 3-year-old you saw in the video, that was not part of the study, but it made him the youngest we've ever seen. The coughing was actually observed in 85 of them during the clinic visit. In other words, some of them during the clinic visit didn't happen to be coughing, but had very convincing histories of consistent with habit cough. So 81 of those 85 were cured within 15 to 30 minutes of suggestion therapy by the clinic physician. These were not all done with me. This was whichever one of our staff was seeing the patient was expected to do that, and they did. Autosuggestion, which is describing to the patient what we would have done if you were coughing when we saw you. We talked to those with a convincing history, but weren't coughing in the clinic. And well, we didn't do a systematic follow-up of those patients. The non-systematic follow-up we did have with quite a number of the patients indicated that it was effective. This is from our study, again, the same 140. This is what gives you information about what the prior duration of the habit cough was. Some of them, of course, if they were so obvious that the parents sought help from it during the first month that they were having symptoms, but then there were an equal number who had been having the cough for over a year. So what is this suggestion therapy? So this is the video.
The repetitive barking cough that is not present once the child is asleep is the diagnostic criteria.
So this was done by Dennis Butner, the father of the girl you're going to see me with. And I'm going to move it along so that we can finish within the hour. Went on for 3 months, obviously difficult to live with.
Hi, I'm Bethany. I'm 12 years old. I could do anything any kid could do before my cough. When I couldn't stop coughing, it made me really sad. Dr. Weinberger taught me how to make my cough go away in only 10 minutes.
I told you, right? The total number?
You don't want to keep count. We just want
No, I'm sure it's 1,200. I planned on recording art.
I'm going to move this along a bit.
And I began to film because no one would believe what we were about to see.
Great girl. You've done it. Over 3 minutes. Hey. Once you cough once, try not to let it happen again. Because try and hold it back. Because you did it for over 3 minutes. Okay. Did it get a little bit easier that time? Mm-hmm. Still hard though, huh? Okay, we're going to go for 4 minutes now.
Now this is her laptop.
You're doing it. You're
I'm talking
to. 3 minutes before you cough.
Mhm.
So I bet you're going to do 4 minutes too. Because you're taking control. You're not letting it control you. So this is what you have to keep doing. You may have to do it for a while. It's going to gradually get easier. Gradually gets easier.
So this was the general idea. I was talking to Bethany in exactly the same way that I talked with over a 40-year period in Iowa, probably hundreds of kids. Colleagues might have had slightly different styles, but we were quite reliable in stopping the cough. The principles here are the approach for any of you who are going to, and any one of you who are going to see children with habit cough should be able to stop it in the same way that I and my colleagues have done, and other physicians, all over the world. So you approach the patient. Oops, starting again. I don't want that.
The repetitive barking cough that is not present once the child is asleep.
Okay. So you approach the child with the mantra from Yoda from Star Wars: do or do not. There is no try. Sometimes someone says, well, try it. No, you don't try it. You approach it from the point of view, you're going to do it. And if you're not going to have that attitude, then don't bother. There, as Yoda said, there is no try. And what you, and this is just a excerpted of the verbal pattern, which is not always the same, but a progressively holding back the cough using sips of warm water, tell them to ease the irritation. We started out using a saline mist, normal saline mist. These are alternative behaviors. Some people get the idea, well, what's the water treatment? No, it's not a water treatment. Okay, the water is to support what you're talking to them about. And along the way, you start telling them it's getting easier to suppress the cough, isn't it? And at which time you nod affirmatively, and they generally say yes. So again, a suggestion. When the suppressed cough is observed, you tell them you're feeling you can resist the urge to cough, aren't you? And again, an affirmative nod. And after 5 minutes without coughing, you say you feel that you can now resist the urge to cough, and that's when you stop. So that was the first time that I had ever done it by remote video conferencing, by Skype. And to my somewhat surprise and pleasure, it was successful. But then following that, there was an unexpected and unintended observations that we learned about because parents and a few adults said that by watching the video, the cough stopped. So this was suggestion therapy for habit cough by proxy. We published a brief report of it back in 2019. And this was the first one that I've got a record of. I'm not going to read the whole thing. but I'll give you some excerpts from it. So our daughter Riley is 7 years old. A few months back, she had a really bad cold, which led to a bad cough, just like that 1694 report. After a few weeks, the cold symptoms went away, except for that cough. There was no stop to it, just so much coughing. And you've heard some of these. And she went on, obviously went to other doctors and describes all that. But she went on to say, I finally decided to just pull your video up on YouTube. And we all sat there and watched it. It was very emotional for all of us. And at the end, Riley was in tears. We all were. We hugged for a time. She said to us, I can hold the cough back. And then the coughing stopped, like turning off a switch. For 4 days now, I have not heard her cough, except for a few random ones here and there. The cough is gone. They're not all quite as dramatic as this one. Some of them take a few days of repeated watching of the video, and the feeling that they have to cough can persist for weeks afterwards, but they've learned to control it, and they have stopped the repetitive coughing, which, as I'll show you, tends to make the be the cause of the cough, that is. This effect by proxy we've now got emails from parents and adults from all over the world that have watched the video and told us that stopped the coughing. The red drops are children, the blue are adults. I won't go into what the others are, the pluses and stuff, but essentially from all over the world, at least the English-speaking world. They've watched the video, and Dennis has arranged for my patter in the video, talking to Bethany, to be translated into Macedonian, Spanish, German, Turkish, and Mandarin Chinese. I don't know how many of those are watched. We don't have that information. We only have the ones where they got back to us with an email. Now, what happens if you don't treat them with suggestion therapy? Well, this is from Mayo Clinic. It was stimulated by seeing my 1991 report. And this was at the North Central Allergy Society that the Mayo Clinic and us and others in the North Central US joined. And they, Dr. Rojas was a fellow and was asked by Dr. Yoger and O'Connell, essentially the equivalent of me at the Mayo Clinic. They went back and they found those where the diagnosis had been made using the same criteria that we had. But there was only explanation and counseling, no specific treatment. They had a follow-up of 62 patients, somewhat of a male predominance, for a mean of 8 years back, looking at records. Ages were same as we had. And the mean cough duration until the diagnosis was made was 8 months prior to being seen. And the mean duration of spontaneous resolution in 46 of them was 6 months. And 16 patients, 25 patients, were still coughing, a mean of 6 years from the time of diagnosis. At the Brompton, they also made the diagnosis the same way we did, as I mentioned earlier, but only explanation was counseling, and explanation and counseling was all that was done. They were able to get follow-up of patients in 39 of the 55. We don't know anything about the rest of them. The median duration of their follow-up was 1.9 years. 26 of the 39, parents believed the diagnosis, and 25 of the 26 eventually resolved. About half of them in the first month, but some of them not till after 6 months. But 13 of the 39 parents disbelieved the diagnosis. They wouldn't accept it. And 7 of those resolved only after a longer period. And at least during the period of follow-up, the others had not yet resolved. Do we have a physiologic explanation for the cough? There's 2 studies that are interesting. One, we know in the vast majority of cases, there's an initial insult, generally a history of a respiratory infection, that apparently is causing inflammation. And there was this study done by Richard Irwin 15 years ago, where he did on adults with chronic idiopathic cough, did a prospective controlled comparative study published in Chest, and I won't go into the details of it, but he did conclude that the repetitive coughing and the inflammation was caused by the repetitive coughing. So that was his explanation. The cough had caused the inflammation. And then there was a study that I don't think it's yet in print. It was online in advance of print the last time I looked, from the American Journal of Respiratory and Critical Care Medicine, who also did biopsies, mucosal biopsies of adults. These were done through bronchoscopy, obviously. And what they found was that there was increased nerve density in the mucosa. And his explanation for that was the cough was the cause of this. The repetitive cough was the probable cause. These were hypotheses. And so essentially you put those together and you have neuropathic inflammation, which is caused by repetitive coughing. And it's that continuous feeling that causes the repetitive coughing, a vicious circle. So now Charlie Brown knows what to do. Okay, the data has been there. So the habit cough recap is identify habit cough by its unique presentation, not by excluding everything else under the sun that causes cough, but it has a unique presentation. It's a clinical diagnosis. Repetitive dry cough, absent during sleep. Treatment is suggestion therapy. There might be various types. People may have different styles, but this has been done now by physicians elsewhere. In Dr. Montini in Argentina has described it. A physician in Bristol, England has described it, and a particular pediatric pulmonologist in South Texas who says the habit cough is the pediatric pulmonologist's nursemaid's elbow, if you're familiar with that disorder. And it both involve cures, rapid cures with no medication, and are very satisfying both to the physician and the patient. So the treatment today is suggestion therapy by the physician, or more and more often it's by proxy. And there are prolonged symptoms if not treated. So moving on now to other causes of functional respiratory disorders. Dysfunctional breathing includes vocal cord dysfunction, hyperventilation, functional dyspnea, habit sighing. So let's look at vocal cord dysfunction. Historical background of this is it was at one time described as hysteria, and then Dr. Osler described physiologically that there was laryngeal muscle with inspiration at times of great stress. There are 2 phenotypes of VCD that have been described. One of the first publications in modern times was in the New England Journal of Medicine in 1983. 5 patients with a diagnosis of intractable asthma were found not to have just asthma, but they had paroxysms of wheezing and dyspnea that responded to speech therapy. And then there was a subsequent study looking at the other phenotype, vocal cord dysfunction masquerading as exercise-induced asthma. 7 elite athletes, symptoms occurred only during exercise. Now, I don't know why people confuse them, because when you look at it, they are opposites and they don't resemble each other. And it's people not paying careful attention when they see the patient, or they obtain a confusing history and haven't really seen the patient. I want to show you a couple of examples. This is a 15-year-old girl with 3 weeks of what was called wheezing and dyspnea. First episode occurred while detasseling. Those not from the Midwest, what detasseling is, it's a Iowa adolescent summer job to create hybrid corn by ensuring cross-pollination. They could make good money in a few weeks' work. She had a second episode the next day while detasseling, same treatment, same result. And we subsequently found that she had large positive skin test to corn pollen. Corn pollen doesn't cover much, doesn't go much further than 100 yards from the yard, from the cornfield. So it's essentially an occupational disease. But she was then having daily episodes without detasseling. She stopped doing that, and without response to the epinephrine. Symptoms both spontaneous and exercise-induced. She was having some spontaneous episodes, and also she was a very active young lady, and it was interfering with exercise. And she'd been treated, of course, as asthma, which she did have. So since this was exercise-induced, we put her on a treadmill, and here's her pre-exercise volume loop, quite normal, and here's post-exercise, at which time she's making that noise. It was an inspiratory noise, and what you're seeing here is normal pre-exercise followed by flattening of the inspiratory loop, diagnostic of extrathoracic airway obstruction. So let's take a look at that.
Okay, now open your eyes and look in there. That's me breathing there. It's on points where I'm showing vocal cords.
Okay, so what you're seeing there was a paradoxical vocal cord movement with closure and inspiration, and that was consistent with what was seen in the pulmonary function. Now here's another girl, Sarah J., 15-year-old again. She had a 1.5-year history of recurrent severe episodes of, again, what was called wheezing, multiple paramedic calls for emergency room visits. She was treated with, of course, for asthma, which she didn't have. She had several hospitalizations and no consistent response to any treatment. So all we had here was the history of this. We decided to perform bronchoprovocation to see if there's any evidence of asthma. And as we're laying out the syringes and the needles, she started, essentially her symptoms were reproduced unintentionally, but fortunately it made the diagnosis. So this is before, and before we started doing anything, just preparing to do bronchoprovocation, and she started in like that. And so she had severe airflow obstruction on both inspiration and expiration. So again, we took a look. you're seeing there is the vocal cords are, closed. She's breathing through a opening of maybe 2 millimeters. But I was trying to get a view of her vocal cords moving normally when she talked. The epiglottis kept flipping into the way. So you'll just watch that for a minute and then we'll move on. We looked at VCD and asthma. With, again, my Doshi is my fellow. The 49 total patients identified with VCD, 41 had a prior diagnosis of asthma, which of course they didn't have. 12 of the 41, 29%, we were able to confirm a diagnosis of asthma, but so they can be occurring concurrently. But obviously the symptoms that concerned them most were not asthma symptoms. So we looked at our experience. 28 of 49 patients with VCD were successfully contacted by Dr. Doshi and my fellow at the time. And the median time was after 3 years. So we had 17 with exercise-induced vocal cord dysfunction only. And pre-treatment, we found from review of the literature that we thought this was vagally mediated and that an anticholinergic ipratropium might stop it. We did observe that in these 5 patients, but we also used ipratropium in many patients, subsequent patients where we did observe efficacy. Nine had spontaneous VCD, like that second girl. 6 attended speech therapy and all attained control of their symptoms. We had 2 with both, like that first patient I showed you, had both spontaneous and exercise-induced. And the ipratropium was effective, or appeared to be effective. These were clinical observations, obviously not controlled clinical trials. So 16 of 17 with exercise-induced vocal cord dysfunction were completely asymptomatic at the time of contact, which is an average of 3 years later. 1 of the 17 continued to use ipratropium prior to vigorous exercise. All 9 with only spontaneous vocal cord dysfunction were asymptomatic at time of follow-up. So the long-term outlook of this is good. 1 of the 2 with spontaneous and exercise-induced remained symptomatic 1.5 years after evaluation, but primarily with exercise and controlled with ipratropium. So the diagnosis of exercise-induced VCD is important, not so much to distinguish from asthma, but to distinguish because they're very different. Any good clinician should be able to tell the difference. But you need to distinguish them from other causes of exercise-induced dyspnea. And to do that, you need an exercise test. You need to reproduce the symptoms, determine what's going on physiologically at those times. So that's essentially the kind of hookup they had, monitoring both respiratory and cardiac physiology at the time they reproduced their symptoms. The diagnosis we came up with a series of 117 patients that went through this was we did find exercise-induced bronchospasm in 11% of those, sorry, 9% of those. Vocal cord dysfunction was also in only 11%. There was restrictive phenomena in 13%, which we don't have time to go into right now. Exercise-induced laryngomalacia occurred in 2%, and exercise-induced hyperventilation occurred in 1%, and exercise-induced ventricular tachycardia in a 16-year-old boy with no palpitations. He only had dyspnea. when he had the VTAC, and that was subsequently fixed. The others were overinterpretation of these adolescents of normal physiologic limitation. They just had normal lactic acidosis that they would try to compensate physiologically with respiratory alkalosis by breathing more and blowing off CO2, but they're asked to do that at a time when they're already at maximum minute ventilation. And that's interpreted by them as being short of breath. Real quickly, in the last couple of minutes, I'm going to go through hyperventilation. And of course, we know what that is. It's often associated with a panic attack. The symptoms are not respiratory. The symptoms are anxiety, dizziness, tingling and numbness of the fingers, toes, carpal spasm. And this is respiratory alkalosis. And they have a decreased PCO2 from the hyperventilation, an increased pH, and a decrease in the free calcium, which is what causes all the symptoms. So the symptoms are not primarily respiratory, and that's important in diagnosing it, especially if you're not seeing it. You have to ask those questions. How do you treat it? Acute treatment is the old rebreathing bag, which increases the PCO2, essentially reverses everything, decreases the pH down to more normal levels, and results in correction of the free calcium. And that's what eliminates the symptoms. If they've been having this repeatedly, then of course they need education and counseling. Nice study of 44 children at the Mayo Clinic with hyperventilation. Girls tended to be more common than boys. And there was a follow-up of 30 children with hyperventilation, also from the Mayo Clinic. And these are the symptoms they had afterwards, 2 to 28 years later, among 30 children. Again, this is children who just had a single episode of hyperventilation. These are obviously children who had gone to Mayo Clinic because they're having it repeatedly. And there was a very high frequency of many ongoing problems years later when they were examined, when they were followed up. Okay, going on to one more, functional dyspnea. This doesn't take much time, essentially. These are children who are breathing maybe somewhat rapidly, but not deeply. Their minute ventilation is generally normal. Their oximetry is normal. Their PCO2 is normal. And essentially, these are anxiety symptoms. They say, I'm having trouble breathing, but physiologically, they're not. And there's one more. Habit sighing. Interesting phenomena. Multiple studies in the literature with it. It's intermittent deep breath. When asked, the patient may express a feeling that they feel they need more air, but this is a completely benign disorder, concerns parents more than the child, but I've had them come to the clinic because the parents are concerned, and the treatment is reassurance of the parents and benign neglect. So the take-home message is cough and dysfunctional breathing can occur in the absence of anatomic or physiologic medical explanation. Habit cough has a repetitive pattern absent once asleep. It's the sine qua non. 2 phenotypes of vocal cord dysfunction, exercise-induced and spontaneous. Hyperventilation, often associated with panic attacks, generally anxiety-induced. Symptoms are from respiratory alkalosis. And exercise-induced dyspnea, if not asthma, requires cardiopulmonary testing for definitive diagnosis. Don't just assume that exercise-induced dyspnea that is not asthma is vocal cord dysfunction, because most of them are not. Functional dyspnea with no abnormal physiology is purely subjective, and habit coughing, habit sighing is benign. So these are my colleagues, Bethany, who was the first person who had suggestion therapy by video conferencing. This is Dennis, who is with us today, her mother, her twin brother, and her younger brother. And that's all for today. Do we have time for any questions?
Hi, this is Andrew Collin. I'm not sure that we have time for questions, but I have to follow on Tassos's introduction. So it's wonderful to see you here. And I want this group to understand that we're looking at the paradigmatic academic physician who has done to this field probably more than most. And, you know, I have to give a personal angle to this. Dr. Weinberger was known as Mr. Theophylline in the early days of modern treatment of asthma. He really knew everything about it. He came to Haifa, Israel, when he was giving grand grounds in Cairo to interview me for a future fellowship that never happened because of ECFNG. And he was my first visiting professor. It's really refreshing and wonderful to see you here so many years later. So thank you for a great talk. And I do have a question. For this habit cough that is so common and so quote unquote easily fixable, what's the background? I am married to a psychiatrist who would ask you, so what's the driver? What's behind it? Why is it so easy to make go away if it's persistently there? Is there an explanation?
Of course, that's the study that yet needs to be done. I can give you clinical impressions from myself and my colleagues who dealt with this in Iowa. We've had the persistent impression that these are, bright, sensitive kids. Is that an explanation, or is that just an explanation of the parents who bring the kids to us? I don't know. I have, we've had a few. I've had a few kids since here in California that had contacted with the parents that had autism, that had chronic cough. It's something that I think needs to be looked at. In other words, we know more about the pathology now, this vicious cycle of coughing causes inflammation, which causes coughing. We don't know what starts it. We know there's a respiratory illness. Is it the nature of the respiratory illness? Is it different than others? We don't know. Or is it the personality of the patient that in some reason makes them prone? From the limited studies that we did back on our 1991 article, we couldn't identify, at least from the standardized testing that was done, there was no signal there of any disorder. One patient had this, borderline high on the obsessive compulsive scale, but even that was, borderline. Whatever the units were, over 70 was on that test was considered abnormal, and this kid had a 70 when it wasn't over. So I don't know. That's a good question. Is there some personality quirk that makes that happen? But they don't go on and get, at least most of them don't go on and get other somatic disorders. So I don't know. What does your wife think?
Well, I never had this discussion with her, but I'm assuming that I would present her this talk. She would say, so what's the explanation? Has any of these kids ever become a Tourette syndrome?
No. And one interesting story, there was a father who had, as he said, mild Tourette's, but it had the full thing. It had the vocalization and all that. And his son also had it. He had, vocal bursts, and some motor tics. And he developed a habit cough. And he responded, let's see, I think he was one who responded to proxy by watching the video. And the father said, that cured the cough, didn't have any effect on the Tourette symptoms.
Interesting. Thank you.
So the father's opinion, who seemed like a very intelligent guy, was that these were totally separate. Unfortunately, often what we have is anecdotes here that raise questions, but there are obviously answers. I would very much interested in your wife's opinion of this.
I will present the recording to her and ask whether she has an opinion. I have to say though that obviously the methodology that you are presenting here is amazingly interesting, and because we are struggling with this.
If I can interject a little, one of the things that I have found useful when I talk to the parents and the patient and trying to make them understand what I'm talking about with the habit cough. And, most of them, have the, the problem that is my child faking? Is it, quote unquote, in his head? All of these problems. So I tell them, that yes, actually, it's one of the few things that you are absolutely right that it is in your head, because it is your brain that tells you to cough, whether you need to do it or not. And what I give them as an example is something that everybody has experienced in the good old days, going to a theater or a movie theater, and one person coughs, and then all of a sudden the entire room starts coughing. And it is very obvious